Welcome to Uber School's comprehensive review of nervous system pathology for USMLE Step 1. I'm Pete, and today we're diving deep into the intricacies of the brain and spinal cord. Crash, are you ready to get neurological?
You bet, Pete. Let's fire up those synapses and get this neural party started. We've got a lot to cover, so let's jump right in with cerebrovascular diseases. First up, ischemic stroke.
All right, Crash. Ischemic strokes are the most common type, accounting for about 87% of all strokes. They're caused by either thrombosis or embolism. In thrombotic strokes, a clot forms in situ, while embolic strokes occur when a clot travels from elsewhere in the body.
Exactly, Pete. And it's crucial to remember that the clinical presentation depends on the vascular territory affected. For instance, if the middle cerebral artery is occluded, you'll typically see contralateral hemiparesis and aphasia if the dominant hemisphere is involved.
Great point, Crash. Now let's talk diagnosis. CT is the initial imaging of choice to rule out hemorrhage. However, MRI with diffusion-weighted imaging is more sensitive for early ischemic changes. Remember, time is brain.
Absolutely, Pete. Speaking of time, let's discuss treatment. Tissue plasminogen activator, TPA, can be administered within 4.5 hours of symptom onset. For large vessel occlusions, mechanical thrombectomy is an option up to 24 hours in selected patients.
Crash, I once knew a guy named Marcus Cooper who claimed he could diagnose a stroke just by looking at someone's eyebrows. He said the left eyebrow would droop slightly in right-sided strokes. Can you believe that?
Pete, that's interesting. But let's stick to evidence-based medicine, shall we? Now, here's a question for our listeners. A 65-year-old man presents with sudden onset of right-sided weakness and difficulty speaking. What's the most appropriate initial imaging study?
Great question, Crash. The correct answer is a non-contrast CT scan of the head. This is crucial to rule out hemorrhagic stroke before considering thrombolytic therapy. Remember, folks, CT is fast and widely available, making it the go-to initial test in acute stroke.
Exactly right, Pete. Now let's move on to hemorrhagic strokes. These bad boys are divided into intracerebral hemorrhage, ICH, and subarachnoid hemorrhage, SAH. ICH commonly occurs in the basal ganglia, thalamus, pons, or cerebellum, while SAH typically results from ruptured aneurysms at the circle of Willis.
Don't forget about the risk factors, Crash. Hypertension is the primary risk factor for ICH, while cerebral amyloid angiopathy is common in lobar hemorrhages in the elderly. It's like a ticking time bomb in their brains.
Whoa there, Pete. Let's not scare our listeners. But you're right about the risk factors. Now, clinically, ICH presents with sudden onset of focal deficits and decreased consciousness. SAH, on the other hand, classically causes a thunderclap headache, the worst headache of your life.
Right you are, Crash. And for SAH, we use grading systems like the Hunt and Hess or World Federation of Neurosurgical Societies scales to assess severity. Now, how about treatment?
Great question, Pete. Management focuses on blood pressure control, reversal of coagulopathy if present, and consideration of surgical evacuation for large hematomas or those causing significant mass effect. It's a delicate balance, really.
Speaking of delicate, let's talk about cerebral aneurysms. These are abnormal dilations of cerebral arteries, most commonly occurring at branch points in the circle of Willis. Saccular or Berry aneurysms are the most common type, while fusiform aneurysms are less frequent.
Don't forget the associated conditions, Pete. Autosomal dominant polycystic kidney disease and Ehlers-Danlos syndrome type 4 are important to remember. Now, for diagnosis, CT angiography is often the initial test, but conventional angiography remains the gold standard.
Absolutely, Crash. And when it comes to treatment, options include endovascular coiling and surgical clipping. The choice depends on aneurysm location, size, and patient factors. It's not one size fits all.
You got that right, Pete. Now, here's another question for our listeners. A 45-year-old woman presents with the worst headache of her life. CT scan shows blood in the subarachnoid space. What's the most likely underlying cause?
The answer, folks, is a ruptured saccular aneurysm. This classic presentation of sudden, severe headache, often described as a thunderclap, along with subarachnoid blood on CT, is highly suggestive of a ruptured aneurysm.
Excellent explanation, Pete. Now, let's shift gears and talk about neurodegenerative disorders. First up, Alzheimer's disease, the most common cause of dementia in the elderly.
Alzheimer's. The key pathological features are extracellular beta-amyloid plaques and intracellular neurofibrillary tangles composed of hyperphosphorylated tau protein. It's like the brain is getting gummed up and tangled.
That's one way to put it, Pete. Genetically, mutations in APP, PSEN1, and PSEN2 genes are important in early-onset familial cases. And don't forget the APOE epsilon 4 allele. It's a risk factor for sporadic cases.
Right, you are, Crash. Clinically, we see progressive memory loss, particularly for recent events, followed by impairments in language, visual spatial skills, and executive function. It's a tough disease for patients and families alike.
Indeed it is, Pete. Current treatments include cholinesterase inhibitors like Dunpizil and NMDA receptor antagonists like memantine. They provide symptomatic relief but don't alter disease progression. We're still waiting for that breakthrough treatment.
Speaking of breakthroughs, did I ever tell you about Marcus Cooper's theory on Alzheimer's? He believed that memorizing the entire works of Shakespeare could prevent the disease. Said something about neuroplasticity on steroids.
Pete, I'm pretty sure that's not evidence-based medicine. Let's stick to the facts, shall we? Now, moving on to Parkinson's disease, a progressive neurodegenerative disorder affecting movement.
Right, sorry, Crash. In Parkinson's, the hallmark is loss of dopaminergic neurons in the substantia nigra pars compacta, leading to dopamine deficiency in the striatum. It's like the brain's traffic light system is malfunctioning.
Interesting analogy, Pete. The cardinal motor symptoms are often summarized as TRAP, tremor, rigidity, akinesia or bradykinesia, and postural instability. It's important to remember that not all patients will have all four symptoms at presentation.
Good point, Crash. Diagnosis is primarily clinical, but DAT scan, dopamine transporter scan, can help confirm dopaminergic deficits. As for treatment, it centers on dopamine replacement with levodopa or dopamine agonists.
And don't forget about deep brain stimulation, Pete. It's a surgical option for advanced cases. Now here's a question for our listeners. A 65-year-old man presents with a resting tremor in his right hand and difficulty initiating movement. What's the most likely diagnosis?
The answer is Parkinson's disease. The combination of resting tremor and bradykinesia, difficulty initiating movement, are classic signs of Parkinson's. Remember, TRAP.
Excellent, Pete. Now let's talk about Huntington's disease, an autosomal dominant neurodegenerative disorder. It's caused by an expanded CAG trinucleotide repeat in the Huntington gene on chromosome 4.
Right, Crash. Pathologically, there's selective loss of GABAergic neurons in the striatum, particularly the caudate nucleus. It's like the brain's inhibitory system is breaking down.
Good analogy, Pete. Clinically, Huntington's presents with a triad of motor, chorea, cognitive, subcortical dementia, and psychiatric symptoms. It's a devastating disease for patients and families.
Absolutely, Crash. And diagnosis can be confirmed with genetic testing, but it raises ethical issues due to the lack of disease-modifying treatments. It's a real Pandora's box.
Indeed, Pete. Now let's move on to brain tumors. We'll focus on gliomas, meningiomas, and metastatic brain tumors. First up, gliomas, the most common primary brain tumors in adults.
Gliomas. The WHO classification grades them from I to IV based on histological and molecular features. Major types include astrocytomas, oligodendrogliomas, and glioblastomas, which is a grade 4 astrocytoma.
Good overview, Pete. For diagnosis, MRI is the imaging modality of choice. And don't forget about molecular markers like IDH mutation and 1p/19q code lesion. They're important for classification and prognosis.
Absolutely, Crash. Treatment typically involves a combination of surgery, radiation, and chemotherapy, with specifics depending on tumor type and grade. It's a multidisciplinary approach.
Now let's talk about meningiomas, the most common extraaxial brain tumors. They arise from arachnoid cap cells and are graded I3 by WHO criteria. There's a strong association with neurofibromatosis type 2.
Right, Crash. On contrast-enhanced CT or MRI, meningiomas typically show a dural tail sign. It's like the tumor's wearing a cape.
Interesting visual, Pete. Treatment depends on location, size, and grade. Many can be observed, while others require surgical resection or radiation therapy. It's a case-by-case decision.
Absolutely. Now, let's not forget about metastatic brain tumors. They're actually the most common brain tumors overall. Lung cancer, breast cancer, and melanoma are the most frequent sources of brain metastases.
Good point, Pete. Metastases typically occur via hematogenous spread and tend to localize at the gray-white matter junction. On MRI, with contrast, they usually show up as multiple ring-enhancing lesions.
Right, Crash. And management may include surgery for solitary accessible lesions, whole brain radiation, stereotactic radiosurgery, and systemic therapy. It's a multi-pronged approach.
Indeed. Now, here's another question for our listeners. A 60-year-old woman with a history of breast cancer presents with new onset seizures. MRI shows multiple ring-enhancing lesions. What's the most likely diagnosis?
The answer is metastatic brain tumors. The history of breast cancer, new onset seizures, and multiple ring-enhancing lesions on MRI are classic for brain metastases. Remember, in adults, metastases are more common than primary brain tumors.
Excellent explanation, Pete. Now let's move on to inflammatory neurological conditions. We'll cover meningitis, encephalitis, and brain abscess. First up, meningitis, inflammation of the meninges, often due to infection.
Right, Crash. Common bacterial causes include S. pneumonia and N. meningitis. For viral meningitis, enteroviruses are often the culprit. The classic triad is fever, neck stiffness, and headache.
Don't forget Kernig's and Brzezinski's signs, Pete. They can be helpful in diagnosis. Speaking of diagnosis, it's confirmed by CSF analysis. Bacterial meningitis typically shows low glucose, high protein, and neutrophilic pleocytosis.
Good point, Crash. And treatment-wise, empiric antibiotics should be started immediately in suspected bacterial meningitis. We're talking vancomycin plus a third-generation cephalosporin here?
Absolutely, Pete. Now let's talk about encephalitis, inflammation of the brain parenchyma, often due to viral infection. Common causes include herpes, simplex virus, HSV, West Nile virus, and in unvaccinated individuals, rabies virus.
Right, Crash. Clinically, we typically see altered mental status, focal neurological deficits, and seizures. MRI can show characteristic patterns like temporal lobe involvement in HSV encephalitis.
Good point, Pete. And don't forget, CSF analysis often shows lymphocytic pleocytosis. Treatment-wise, acyclovir should be started empirically in suspected HSV encephalitis. Other treatments depend on the specific etiology.
Absolutely, Crash. Now, let's talk about brain accesses, focal collections of pus within the brain parenchyma. The stages of formation are important to remember: early cerebritis, late cerebritis, early capsule formation, and late capsule formation.
Good overview, Pete. Risk factors include endocarditis, sinusitis, and immunosuppression. Diagnosis is typically made with contrast-enhanced CT or MRI, which shows a ring-enhancing lesion with surrounding edema.
Right, Crash. And treatment involves antibiotics and often surgical drainage. Empiric antibiotics should cover streptococci, staphylococci, and anaerobes. It's like a microbial party in there.
Interesting analogy, Pete. Now here's a question for our listeners. A 30-year-old man presents with fever, headache, and neck stiffness. Lumbar puncture reveals cloudy CSF with low glucose, high protein, and neutrophilic pleocytosis. What's the most likely diagnosis?
The answer is bacterial meningitis, the classic triad of fever, headache, and neck stiffness, along with the CSF findings of low glucose, high protein, and neutrophilic pleocytosis, are characteristic of bacterial meningitis.
Excellent explanation, Pete. Now let's wrap up with demyelinating diseases. We'll cover multiple sclerosis, Guillain-Barré syndrome, and acute disseminated encephalomyelitis. First up, multiple sclerosis, MS.
MS, an autoimmune demyelinating disease of the central nervous system. It's characterized by inflammation, demyelination, and axonal degeneration. Clinically, presentations vary widely but often include visual disturbances, sensory symptoms, and motor deficits.
Good overview, Pete. Diagnosis is based on the McDonald criteria, which incorporate clinical and MRI findings. Typical MRI shows multiple white matter lesions disseminated in time and space.
Right, crash. And treatment-wise, various disease-modifying therapies are available, including interferons, glatiramer acetate, and monoclonal antibodies. It's like we're building an army to fight the disease.
Interesting analogy, Pete. Now let's talk about Guillain-Barré syndrome, an acute autoimmune polyneuropathy. It's thought to be triggered by preceding infections leading to autoimmune attack on peripheral nerves.
Right, crash. The classic presentation is ascending symmetric paralysis. And don't forget about the Miller-Fisher variant, which presents with ophthalmoplegia, ataxia, and areflexia.
Good point, Pete. Diagnostically, CSF typically shows albuminocyclogic dissociation. Nerve conduction studies may show demyelinating or axonal patterns. Treatment-wise, IVIG and plasmapheresis are equally effective.
And don't forget about supportive care. Crash. Ventilatory support might be needed in severe cases. It's like we're providing a life support system while the body heals itself.
Indeed, Pete. Now let's finish with acute disseminated encephalomyelitis, ADEM, a monophasic demyelinating disease. It often follows viral infections or vaccinations and causes widespread demyelination in the brain and spinal cord.
Right, crash. ADEM presents with acute onset of multifocal neurological deficits and encephalopathy. Treatment primarily involves high-dose corticosteroids. It's like we're trying to put out a fire in the nervous system.
Interesting visual, Pete. Now here's our final question for the listeners. A 25-year-old woman presents with weakness in her legs that has been ascending over the past week. She reports a recent upper respiratory infection. What's the most likely diagnosis?
The answer is Guillain-Barré syndrome. The ascending symmetric weakness following a recent infection is classic for GBS. Remember, it's an autoimmune condition triggered by a preceding infection.
Excellent explanation, Pete. And with that, we've covered a wide range of nervous system pathologies. Remember, folks, understanding the pathophysiology, key clinical features, and fundamental management principles for each condition is crucial for acing the USMLE Step 1.
Absolutely, Crash. And don't forget to review the questions we've discussed throughout this session. They're great examples of the types of questions you might encounter on the exam.
Couldn't agree more, Pete. Well, that wraps up our Uber School review of nervous system pathology for USMLE Step 1. We hope this helps you all in your studies. Remember, every neuron counts.
And on that note, Crash, I'm reminded of Marcus Cooper's famous words, "The brain is like a muscle. The more you use it, the stronger it gets." While that's not entirely accurate from a neurological standpoint, the sentiment holds true for studying. Keep at it, everyone.
Well said, Pete. Thanks for tuning in to Uber School, folks. Until next time, keep those synapses firing.